Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anis Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about Ewing Sarcoma with Dr. Harry Deshpande and his patient Julia. Dr. Deshpande is an associate professor of medicine and medical oncology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Julia, maybe we can start off by you telling us a little bit about yourself and a bit about your story.
Yeah, absolutely. I feel honored to be here, so thank you so much. I'm a 30-year-old woman. I was diagnosed with Ewing sarcoma in 2015, so quite a while ago. And it was to my surprise. I was in PA school, physician assistant school. I was in my graduate year and had been having some pain for a while. And I got a workup and, got the diagnosis. Had to take off about a year and a half of school to do upfront therapy. And that was very difficult. Being 22, starting my career, to be a PA, and I was so excited, and this kind of really threw a big wrench in my life plans, as cancer diagnosis often does.
Yeah.
So at that point, I started my therapy at Yale, in actually the pediatric world, because it's pediatric cancer and young adult cancer, but often in younger children. So I did that therapy, and then there was there were more bumps along the road. There were multiple relapses, and while I was having these relapses, I decided to go back to school and get my degree. So I did finish and become a physician assistant. So that was really a very proud part of my journey. And then as things progressed, I started to incorporate my cancer as part of my life, and instead of something that hindered my life. And so I decided that I really wanted to work in oncology. So I, at the beginning of my career, got my first job at Mass General in pediatric radiation oncology. And so I worked there for several years at the beginning of my career while getting my treatment. And so as things had progressed, there are many bumps along the road, as many cancer patients experience, and many relapses, and this about a year or so ago, there was a pretty big shock to everybody, and that was when I contacted Dr. Deshpande, because it had the cancer had spread to my brain, and so that was pretty shocking. And my life again was halted pretty severely, and Dr. Deshpande was there and supported me, and he's a really special man.
Well, that's fantastic. And Dr. Deshpande, Hari, I want to bring you into this conversation just to kind of flesh out a little bit more about what exactly is Ewing sarcoma. So can you kind of tell us what it is and a bit about the demographic that is affected by it and how it presents?
Yes, so thank you, Anis. It's nice to see you again, and it's great to see Julia here. It's a rare disease, so it's not quite 1 in a million, but it's probably 2 or 3 in a million. So it's not surprising that people haven't heard of it. And even when you're at PA school, it's probably not high on your list of lectures that you hear about. But Julia's absolutely correct. It's mainly a disease of children and young adults. In children, it's almost always a disease of the bone. In other words, it starts in one of the bones. In adults, it can start either in the bone or in what we call the soft tissue. So that's other areas of the body. And if it does occur in the bone, and you may remember this from your medical school lectures, Anise, it can have a very characteristic appearance. We call it an onion skinning appearance in the shaft. So, but it's difficult to predict where it's going to occur and who it's going to occur in. It doesn't seem to have a specific cause. Some cancers that we see, we can say, oh, this runs in your family, or you got this because you work around nuclear material or something like that. But that's not really the case with Ewing's.
And so, Julia, when you were telling your story, you had mentioned that this started with pain. Can you tell us a little bit more? I mean, certainly when you're 30 years old, you're a PA student. I can't imagine that you were thinking, if I have some sort of pain, this is going to be a Ewing sarcoma. So can you tell us a little bit more about what was this pain? Where was this pain? And what actually brought you to the doctor? Because many of us, I would think, would shrug that kind of stuff off.
Absolutely. I second what Dr. Deshpande says about not learning much about Ewing's in PA school. I don't even know if we learned about it. So it wasn't on my mind. But at 22, it was definitely not on my mind when I was having some pretty severe pain in my right hip. But it presented as a sciatica type of presentation. So some numbness kind of down my leg and in my glute muscle. And so that it started kind of vague and it would be on and off. And so I started physical therapy, which is often the case, this kind of typical course of, I'm sure Dr. Deshpande would agree that, usually they see, you go to physical therapy and you kind of do exercises and see if it gets better. And it did get better for a bit. And then it got worse again. And then it got better and it got worse. And that was about 9 months. And I saw an orthopedist who had diagnosed it piriformis syndrome, which is again, something that would be relieved with stretching and exercises. So I would start to do those, and it didn't improve. So actually, a rheumatologist, he was the one who had done a very thorough exam and ordered the first image. And that was 9 months after the beginning of my pain. So I finally got an image, and the image showed the tumor in my right pelvis. And I was metastatic at diagnosis, so it had spread to my lungs at that time, likely because of the length of time it took to find it. So again, that vague type of pain could be many things, right? We don't think of the zebra, all the time. And so I think that I look back on that time and I have, of course, feelings about wishing I had pushed for an image, but it wasn't really standard of care to do that.
Yeah. So, Hari, can we pick up on this conversation in the sense that, understandably, right? You would think common things being common, this is going to be, a muscle pull, it's going to be piriformis syndrome, it may even be sciatica, you should do physical therapy. Is there often a delay in that diagnosis? And how is the diagnosis actually made?
I think both you and Julia just picked up on the main problem with this presentation, is that it is a very, very rare disease. And so when you see people who don't see this every day or may not ever see this, then it's not something they're thinking of. And that's why it's important, really, in all of medicine. If something doesn't get better in a time frame that you expect it to get better, it is worth taking a look to see whether it's something else. But that's a very general statement, and that time frame can be a very long time, unfortunately. But if you are thinking about either Ewing sarcoma or another, what we call a primary cancer of the bone, or even any abnormality in the bone, the first thing that we really want to do to make a diagnosis is to get a biopsy. So, and this can be done in many different ways, but the most common is to somehow get a needle into the area of concern, get a small piece of tissue, which our pathologist can then look over and hopefully make a diagnosis. The problem with sarcomas in general is sometimes if any surgery is going to be done after the biopsy, then they have to not just remove the lesion itself, but remove the entire biopsy tract. So in other words, if the needle goes into the skin and then through the muscle and to the bone, they have to resect that whole area that the needle went through if they're going to do surgery. And so we have a special radiology service, which many tertiary centers have, who are very experienced in doing these biopsies, and that's what they will do to make sure they do it in the safest but also the best possible way.
Presumably, a bone biopsy doesn't tickle. Is that done under anesthesia? I mean, it sounds like it's certainly not something that you would do in the office.
It depends what kind of bone biopsies. So in my earlier days, I used to see some hematology patients, and a bone marrow biopsy can be done in the office. And I would say most of our biopsies are done as an outpatient. For someone like Julia, who we're looking at a particular area, then you do have to use a type of guided biopsy. In other words, some kind of imaging to guide the biopsy needle where it's going to go. And I can't remember, Julia, what they used with you. Do you remember? Or was it a CAT scan or an ultrasound? But that's usually
I think it was an ultrasound.
Yeah, that's typically how we do it. So.
Julia had mentioned that her cancer was metastatic at the time of her diagnosis. So, Julia, where had it spread by the time it was diagnosed?
At the time of diagnosis, it had spread to my lungs. I had a couple lung nodules, which is, Dr. Deshpande will comment on it, but I think a very common place that the sarcoma will spread to. So there wasn't any other organs, and I did have a bone marrow biopsy that he had mentioned, which was negative. So the primary tumor had spread to the lungs only at that time.
Well, we need to take a short break for a medical minute, but please stay tuned to learn more about Julia's story and Ewing sarcoma with my guests, Dr. Hari Deshpande and Julia.
Support for Yale Cancer Answers comes from Smilow Cancer Hospital, where their prostate and urologic cancers program provides a multi-specialty team dedicated to managing the diagnosis, evaluation, and treatment of bladder cancer. SmiloCancerHospital.org. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications, as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guests, Dr. Hari Deshpande and Julia. Now, we're talking about Julia's cancer journey with Ewing sarcoma, and right before the break, Julia was mentioning that her pain was in her hip. They thought it might be sciatica, might be piriformis syndrome. Ultimately, a rheumatologist sent her for some imaging. She had a biopsy and ultimately was diagnosed with Ewing sarcoma. But by the time she was diagnosed, it had already spread to her lungs. So, Hari, is that common that at the time of diagnosis, most patients are already metastatic?
That's a good question. I don't know the exact numbers. We do see patients who it's what we call localized, so it hasn't spread anywhere. But if it is going to spread, then the first place it usually spreads to is the lung, just as Julia says. And with bone sarcomas, we actually have different stages. So people listening have probably heard of stages of cancer. And with sarcomas, we have a stage for if it spread to the lungs, but it's 4A if it spread to the lungs, whereas it's 4B if it spread somewhere else. And the reason we do that is even if it spread to the lungs, we still treat very, very aggressively. As Julia said, she got over a year of chemotherapy and other treatments as well. And that's because we know that people like her can get treatment and do well for years. So it's not like other cancers where if it has spread to the lungs from somewhere else, then we may be scaling back on treatments because we're not sure how well they'll do with very aggressive treatments.
Yeah. And so, Julia, I can only imagine what it must have felt like being 22 in PA school and being told that you had metastatic sarcoma. Can you talk a little bit about kind of how you felt at that moment? I mean, was this despondent? Was it optimistic and I'm going to fight? What was your emotional response to this diagnosis?
Yeah, I think I oscillated back and forth between many different emotions. Anger is not a very common or a familiar emotion for me. So I would say probably sadness and fear. I have a close friend who's a childhood cancer survivor who really stepped up for me and was kind of my main support. And it was enormously helpful. I had a tribe, for lack of a better word, and people, my girlfriends came together, and when my blood counts were okay and safe to go places, they would throw a head wrap on like me, and we would all go somewhere safe, go to a restaurant or something, and we all would have head wraps on. So I didn't have to feel different. And it was those little things that made an enormous difference in that year and a half of treatment. And I had to relocate for some radiation up to Boston. And that was a difficult part of the journey for me, knowing that I was leaving my support system, my family and my friends. And they traveled at least twice a month up there to do the same thing and, bring my spirits up. And I do remember specifically just feeling that love kind of, it didn't make the fear go away, but it felt a whole lot less lonely. And so I'm forever grateful for the time and effort that my tribe, put in for me. And I wouldn't be where I am today without them. So
yeah, I think we all need a tribe, whether we're going through cancer or anything else in our lives, but particularly when you're facing that kind of a diagnosis that's scary and, just knowing that you've got people around you who love you and care for you and will go through that with you, or at least stand by you as you go through it, so that you're not alone, is so important. Hari, can you talk a little bit about the treatment itself? I mean, on this show, we talk a lot about different modalities of treatment, whether it's surgery, radiation, chemotherapy, immunotherapy. And we talk about this multidisciplinary kind of approach to cancers. Can you talk a little bit about how sarcomas and Ewing sarcoma in particular are treated?
Yes, so I'm glad you mentioned the multidisciplinary approach. We have a tumor board which meets once a week, and any patients who we see, either if they're seen by the surgeon or by myself or by one of the radiation doctors, are presented at that meeting, and we come up with a treatment plan. And that can involve, just like you said, either surgery, radiation, or some kind of what I call systemic treatment. So that could be chemotherapy or immunotherapy, or a combination of 2 or even 3 of them. And for Ewing sarcoma, I think you have to go back to the early 1900s when it was first discovered and named. And at that time, there were very little treatments for it, and most people, even if it was localized in one area, did very, very badly with the disease. But then in the 1960s and 70s, when chemotherapy was being developed, they started using it on children with different kinds of cancers. And Ewing sarcoma had a really very good response to the initial chemotherapy regimens. And eventually they came up with a treatment that was a combination of 3 different chemotherapies, all given together, given every 2 or 3 weeks. And for the first time, people were surviving with Ewing sarcoma. It was not seen before. And even the people who had a relapse after that had a good response to a second-line treatment. And so many people make fun of oncologists because they say, well, if one medicine doesn't work, how about we add another one to it? And that's exactly what they did. So they gave the first regimen, waited 3 weeks, and then gave the second round treatment, and then went back to the first round treatment. So it's an alternating chemotherapy of really very high doses of medications. But as a result, the survival rates went way up from very, very low numbers to many people with localized disease doing very, very well with the condition. The downside is it's a long treatment, so 48 weeks of chemotherapy is very daunting when you're talking to someone, especially young people, about what they have to face. But after that, we often, in between, I should say, in the middle of that treatment, we often do either surgery or radiation or both to try and control the place where it started. And that's typically the treatment definitely for localized disease and often for metastatic disease as well.
And so, Julia, it sounds like you started on this long journey of chemotherapy. I mean, 48 weeks, my goodness, that's almost a year. And you mentioned that you had to relocate for radiation therapy. Why was that? Was it because the radiation that you required wasn't available where you were being treated, or was it for a particular clinical trial? Can you tell us a little bit more about that?
Yeah, absolutely. So surgery and radiation were both on the table for me. However, the surgery would be pretty morbid, so radiation was the choice that we made, and I relocated because of the location of the tumor, and Boston has something called proton beam radiation, which is a certain type of radiation that can spare surrounding tissues of radiation. And given that it was in my pelvis, my ovaries are there and many other important organs. And so the radiation oncologist here at Yale had said, I think that this is this is the best type of radiation for you, and referred me up to Boston.
Yeah. And Hari, Julia had mentioned as she was telling her story that she had many relapses. Is that kind of classic for Ewing sarcoma, that people will relapse? And what are their options at that point? Are there clinical trials that are ongoing?
Unfortunately, the relapse rate is quite high for metastatic Ewing sarcoma. We do have other, what we call salvage treatment options, and Julia's had some of those already. As far as clinical trials, I know Julia was on one up in Boston. We did have one specifically for Ewing sarcoma probably about 10 years ago. It did not do very well in terms of the results were not very promising. And I like to keep in touch with my colleagues from pediatric oncology. As Julia also said earlier, this is a disease that affects children a little bit more than adults. So most of the trials will include very young children, and they'll have an upper age group of 30, sometimes up to 50. And I will be involved in some of the older patients. So at the time that Julia was diagnosed, we didn't have an available trial, but definitely when one opens, Julia will be first on my list.
So Julia, it sounds like you went up to Boston, you had your radiation, you had more chemotherapy, and then it sounds like life was going along well, and then you relapsed again and again. Tell us about what that was like, how those relapses were found, and how you were treated, and if at any point you kind of went, oh my goodness, like here we go again, how much more is this going to be?
Yeah, those thoughts definitely crossed my mind here and there for sure. But yeah, so I enrolled on a clinical trial in Boston, and at that time I had passed my physician assistant boards and said to myself, I'm going to continue my life and try to incorporate the cancer into my life. So I was on this clinical trial for about 5.5 years while I was working in Boston. So that was an interesting, beautiful, challenging, all of the above experience. And during that time, had relapses multiple times, about 3 or 4 times, and we would locally treat the area, and I'd continue on the clinical trial, and I would be monitored very closely. And then that was feasible with living and working because I had pretty minimal side effects from that systemic treatment and those local treatments. And then when it spread to the brain, that was really kind of the decision maker that, this clinical trial is not the best course anymore. And it's time to take a pause and really think about where I'm going next.
Julia is a patient of Dr. Harry Deshpande, an associate professor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.